Welcome to your custom deep dive. Today we have a very clear mission, We are unpacking the mechanics of high-quality CPR, specifically for an Australian clinical audience.
Right, and we're looking at sources strictly aligned with the Australian Resuscitation Council, or ARC, guidelines.
Exactly. And to really grasp the physics behind these ARC guidelines, we kind of have to throw out the whole Hollywood version of a resuscitation.
Oh, absolutely.
Yeah.
I mean, in an active code, saving a life isn't about some dramatic rush to push adrenaline. It's not about plugging in expensive machines.
It is entirely about the plumbing.
Yes. You are essentially taking over the hydraulics of the human body.
So let's unpack this plumbing analogy. We have to become the patient's engine. I noticed the sources emphasize a very specific compression rate, like a sweet spot of 110 beats per minute.
Right.
Why that specific number? It seems a bit counterintuitive that going faster wouldn't be better in an emergency.
Well, if you push that rate too high, say 140 beats per minute, the heart never actually gets a chance to refill with blood. Think of a sputtering water pistol.
Oh, that makes perfect sense.
Yeah, if you just mash the trigger repeatedly without letting it reset, nothing comes out. You have to give the chambers time to fill before you can pump anything forward.
Which brings us to depth. The ARC guidelines dictate compressing at least 5 centimeters.
At least 5, yes.
In a clinical setting, maintaining that depth has to be incredibly physically demanding, right?
It really is. Code fatigue is a massive factor here. The sheer physical exhaustion of a long resuscitation can subconsciously cause you to shallow out your compressions without even realizing it.
You have to overcome that psychological hesitation of pushing too hard.
Exactly, because if you aren't displacing at least 5 centimeters, you are just squishing surface tissue. You are completely failing to squeeze the ventricles.
I understand that pushing down is what actually pumps the blood out, but the sources put a massive emphasis on letting go.
Yes, the recoil phase.
Why is the release phase treated as heavily as the compression itself?
A great way to visualize this is to think of a fireplace bellows. When the chest springs back on the upstroke, it creates a vacuum inside the chest cavity.
And that pulls the blood in.
Literally pulls blood from the venous system back into the heart. If you lean on the chest, even 1 or 2 millimeters of your body weight on it, you destroy that delicate vacuum.
So the tank doesn't refill.
Right, and your next compression just pushes an empty chamber.
So if we are acting as this highly precise hydraulic pump relying on a vacuum, what happens when we inevitably have to stop? Like to check a monitor or secure an airway?
The guidelines are rigid about this. Keep pauses under 5 seconds.
Because blood flow isn't a light switch.
Exactly, it has inertia. When you start compressions, you face a time tax. There's a priming lag of about 4 seconds.
Which is roughly 5 to 8 compressions.
Just to rebuild the coronary perfusion pressure, that is the actual pressure needed to push blood into the heart muscle itself.
So stopping for even a few seconds means starting the hydraulics completely from scratch.
The pressure crashes immediately. The heart starves.
If that chest recoil creates a delicate vacuum to pull blood in, how does forcing oxygen into the lungs impact that system? It's tempting to just flood a patient with oxygen.
That is the paradox of breathing during a code. That temptation is exactly why ventilation discipline is vital. You only want a half-bag squeeze, just enough for visible chest rise.
Because overinflating creates high intrathoracic pressure.
Yes, it literally acts like a physical wall inside the chest, strangling the heart by blocking the venous blood from returning to it.
And it pushes air into the stomach, causing gastric inflation.
Which you definitely want to avoid.
So looking at the big picture here, pumping, letting go, strict pauses, tiny breaths, does CPR itself actually save the life?
Rarely on its own. It is a time buyer. It primes the engine so that early defibrillation can effectively reset the correct rhythm from ventricular fibrillation.
But the shock won't work on a starved, unprimed heart.
Exactly.
It's all just the ultimate setup, which leaves you with a pretty powerful irony to reflect on. In the most critical moments of human life, advanced medicine isn't about AI or complex tech.
No, it's the profound mental discipline required to perfectly execute basic manual labor while chaos explodes around you.
If this helped, enroll in our full ARC-aligned ALS course for 10 CPD hours and a personalized certificate that shows your chosen location, perfect for travel or rural portfolios. $299 AUD at lifesupportinstitute.com.au.